So welcome everyone to the special webinar hosted by CVPath and supported by Cellanova Biosciences. Tonight we'll be speaking about cardiac injury and PCI in the era of COVID-19 from Cath lab to pathology lab. I'm Dr. Alok Finn, an interventional cardiologist and cardiovascular researcher and medical director of CVPath Institute here in Gaithersburg, Maryland. Tonight we have with us many esteemed speakers who will tell us about different aspects of the effects of COVID-19 on the cardiovascular system. We welcome Dr. Renu Vermani, a world-renowned cardiovascular pathologist and president of CVPath Institute, Dr. Robert Byrne, an internationally recognized interventional cardiologist and cardiovascular clinical trialist from the Cardiovascular Research Institute in Dublin, Ireland, Dr. Giulio Guaiumi, an interventional cardiologist and specialist in intravascular cardiovascular imaging from the Hospital Papa Giovanni XXIII, located in Bergamo, Italy, Dr. Jay Matthews, an interventional cardiologist and nationally recognized for his clinical excellence in coronary, peripheral, and structural heart disease from Manatee Memorial Hospital in Bradenton, Florida, and Dr. Rajiv Johar, an interventional cardiologist and chief of the Department of Cardiology of the North Shore University Hospital in New York. Let me briefly review with you tonight's agenda, and we'll try to make this as packed with new information as possible. Dr. Guaiumi will start off by giving us the Bergamo experience in terms of his COVID experience and case-based presentation of COVID-19 and ACS. That will be followed by Dr. Vermani, who will tell us about the pathology of COVID-19 induced cardiac injury. We'll then have about 5 minutes for question and answer, and I'll talk about this in a minute. That'll then be followed by 10 minutes of Dr. Robert Byrne speaking about potential treatments under evaluation, focused on hypercoagulability and anticoagulation as treatment strategies. I will then speak about thromboresistance of different stents compared under simulated cytokine storm conditions. Then Dr. Matthews will give a case presentation. He'll tell us about the current status of COVID-19 in Florida and what to do. What do I do if I have a COVID-19 patient with ACS, understanding thrombotic risk? That will be followed by Dr. Johar, who will present his case experience of COVID-19 in New York and present a high bleeding risk COBRA case. We will then have about 10 to 15 minutes for question and answer, and that will be followed by a 7-minute wrap up, which I will try to summarize all the speakers. If you would like to ask a question to any of the speakers, we ask that you use the Q&A text function in your Zoom app. We will get to as many as possible during the Q&A sessions, and please ask them at any time. Thank you once again for joining us, and I hope you enjoy the webinar. So we're going to start the talks out, as I mentioned, with Dr. Guaiumi presenting the Bergamo, Italy COVID experience and case-based presentation of COVID-19 and ACS. Welcome, Giulio.
Hello, I'm Dr. Guaiumi from Ospedale Papa Giovanni, Bergamo, Italy. Happy to be with you tonight at this cardiac injury and PCI virtual meeting in the era of COVID-19. 1,000 patients with ACS were missed out on life-saving treatment since the start of the COVID-19 outbreak. It was truly an obstacle course to try to get reperfuse of these patients. The most efficient EMS were flooded by calls of patients in severe respiratory distress. During a 40 days period starting on February 23rd, my hospital admitted more than 1,400 patients with interstitial pneumonia, and hundreds of them were requiring ETI or advanced ventilatory support. The network was completely disrupted. No chance to get in contact with your doctor. The phone lines were saturated. No chance to have one ambulance. And then a major obstacle in transferring the patients to the hub center, in wearing the PPI, and then again in deciding which type of therapy. There is a clear evidence recently published in the literature that the coagulopathy is associated to an endotheliopathy in COVID-19. Here you can see the Volt-Willebrand antigen activity and the factor A activity in COVID-19 patient hospitalized in the ICU and non-ICU department compared to the normal range. Incredible augmentation of a coagulation factor and changes in spontaneous fibrinolytic What about the injury? Well, we know that in COVID-19 infection, myocardial injury is quite frequent, but for the vast majority is very mild or moderate in entity, with some exception. And the exception is not only having an incredible risk if you have a cardiovascular disease or if you have a cardiovascular risk factor, but also in patients that do not have neither cardiovascular disease, neither risk factor. When you are increasing the troponin level significantly, you might have an incredible increment of the hazard ratio. Meanwhile, we were exposed to the data that were showing as in STEMI patients with COVID-19, quite a significant percentage of these patients arrive with a non-identifiable culprit lesion, so apparently normal epicardial coronary vessel. And the outcome was absolutely not favorable, and it was associated with a reduction of the left ventricular ejection fraction. For this reason, we focus in co-sharing with the CVPath and Dr. Finn and Virmani on the cardiac injury in COVID-19 as a pathology systematic analysis study. All the heart obtained at autopsy from Bergamo were transferred to the CVPath to be deeply analyzed. What we had, number one, we had the patients coming to us. This is a case, lady, 43 years old, no cardiovascular risk factor. She was assisting her husband, who was hospitalized for COVID-19 interstitial pneumonia the same day when she was starting to suffer chest pain. ST segment elevation in the inferior and lateral lead. She was quickly transferred to our hub. Then she was arriving clearly hypotensive and tachycardic with a very significant low ejection fraction with akinesia at the level of the inferior and lateral wall and some pericardial effusion. Put on the table immediately to check the coronary artery. The coronary arteries looks normal at the epicardial level with some persistent blush at the level of the distal right coronary artery. So we support immediately here by using intra-aortic balloon pump and inotropes. Here you might see the chest X-ray where there was a redistribution toward the apical part of the flow, but no interstitial pneumonia. She was tested positive to the nasopharyngeal swab immediately performed, and she was transferred to the ICU. Here you have all the essential information, including the hours after the hospitalization, then the vital sign, then the lab data. As you can see, this situation went quite quickly in the wrong direction, despite the inotropes and the intra-aortic balloon pump support. She was becoming systematically hypotensive. So because she had a normal coronary epicardial vessel, we were thinking about a myocarditis. So we treat here by using duronavir and a high dose of methylprednisolone and immunoglobulin in infusion with escalating dose of inotropes, and she was quickly deteriorating in terms of lactates, in terms of multi-organ failure. Quite important to understand that the coagulation system in this lady who came with the diagnosis of STEMI was completely changed with a significant increase in prothrombotic fragment F1 plus F2 and the von Willebrand factor, as we previously mentioned, but also a dramatic increase in the inhibitors of PI. And she died in 46 hours. So this is the pathology assessment, then at the CVPath. So from a macroscopic point of view, you might see there were regional myocardial infarction on the lateral wall, inferior wall, extended to the inferior wall, also to the right ventricle. This patchy myocardial infarction was extending from the endocardium to the epicardial, with contraction band, with some inflammatory infiltrates, but very relevant. All the small vessels were filled by fibrin-rich and platelet-rich thrombi, as was documented by this positive CD61. And they had immunofluorescence. The vessels were positive for VE cadherin, one endothelial marker, and positive also for CD61, CD42, that is a platelets marker. What about PCR IL-6? So we searched systematically in the entire heart, and you can see that it was clearly detected at the level of the inferior wall of the right ventricle, inferior wall, and with some involvement on the septum. The lungs show some pulmonary edema with a microthrombi, and so microthrombi were diffusely observed at the level of the kidney and the level of the spleen. No virus was detected inside this heart. So the major message from this clinical case is don't mistake microthrombi for myocarditis in COVID-19 patient presenting apparently with STEMI. And I think the major conclusion is the case challenge the traditional differential diagnosis of STEMI in the setting of COVID-19 and reveal the potential for microvascular thrombi in absence of epicardial coronary artery disease to be responsible for acute myocardial infarction. So new therapeutic options needed to be explored for these microthrombi. They are observed at the level of the multi-organs. Thank you very much for listening to me.
Julia, that was excellent. Thank you so much for that. Next, Dr. Vermani is going to talk about the pathology of COVID-19 induced cardiac injury.
I'm Renu Vermani. I'm going to talk on pathology of COVID-19 induced cardiac injury. These are my disclosures. I'm going to divide my talk into 4 portions. First, I'll talk on the prevalence and impact of myocardial injury in patients hospitalized with COVID-19. Then I'll talk on the prevalence of persistent myocardial injury in patients recently recovered from COVID-19. Then I'll give you an idea of what ischemic injury, that it is common in COVID-19 patients from our autopsy cases, and myocarditis is infrequent in COVID-19 patients. The prevalence and impact of myocardial injury in patients that were recently hospitalized with COVID-19 at New York Mount Sinai Hospital. They admitted 2,736 patients and measured troponin I within the 24 hours after admission. The mean age of these patients was 66 years and 59% were men. 985 patients had elevated troponin I concentrations beyond more than 0.005. And of these, 506 patients had died during hospitalization. They divided the patients of troponin I into 3 groups: 0 to 0.003 nanograms per milliliter, which is the normal range, then those between 0.03 to 0.09, and those greater than 9. They looked at the outcomes of hospitalized, discharged patients and those with mortality shown in orange. And you can see the probability of mortality is extremely low if your troponin is normal range. However, when troponin levels even moderately elevated from 0.03 to 0.09, mortality increases. The mortality is highest in those with greater than 0.09 nanograms per deciliter. So looking at the outcome of cardiovascular magnetic resonance imaging in patients recently recovered from COVID-19, of a total of 78 patients who had recently recovered from COVID-19, 78% had abnormal CMR. Now, I'm going to now address mostly our own work, which is based on autopsy evidence of myocardial necrosis and the type of thrombosis on autopsies that were performed at Papa Giovanni Bergamo Hospital in Italy under the supervision of Dr. Guayumi, who spoke just before me. Now, of the 40 autopsy cases that we've looked at of COVID-19, 32.5% were positive for myocardial necrosis. What were these myocardial necrosis from? 3 had myocardial infarction. Myocardial necrosis occurred in 10. 3 had coronary thrombosis. And 4 of the 13 cases had severe epicardial coronary disease. Intramyocardial microthrombi were seen in 7. And in 2 of the 13 cases, there were LV thrombi. And in 5 of the 13 cases, there were also evidence of lung thrombosis, as shown here. Now, I'm showing you photographs and photomicrographs and some drawings dividing our cases into 2 types. Notice those that had thrombus in the epicardial coronary artery and those that had microthrombi in capillaries. There were multiple in some and they were focal in others. And shown here is an infarct, you can see, and the aspirate of that infarct that patient underwent after he had acute myocardial infarction. He underwent coronary angiography, the aspirate was removed, and this aspirate was examined. And similarly, we did in multi-regional, you can see multiple microthrombi in this case, but in this particular case, it started with microthrombi, which were, or an ST elevation MI that had occurred in the septal and inferior wall, but also involved the right ventricle. Eventually, at the time of death, it was circumferential microthrombi. This patient had very few microthrombi, mostly epicardial based. Now, as you can see here, what was most dramatic here is the epicardial thrombi are CD61 positive, fibrin positive, von Willebrand positive, D-dimer positive, but C5b9 complement negative. Whereas the microthrombi, on the other hand, are CD61, von Willebrand, fibrin positive, D-dimer positive, but also C5b9 complement positive. Those are the basic differences, and I'll show these differences more dramatically because we assess them quantitatively. We compared the epicardial coronary aspirates obtained from non-COVID to COVID positive patients, N of 5. These are in blank, this is in blue, and the microthrombi are shown in pink. And as you can see, CD61 is not significantly different, but it seems to be increased in those with COVID. Same way, in a way, von Willebrand factor is slightly higher in the microthrombi, but not so in those who have epicardial coronary thrombosis, but this was not significant. Fibrin true was significantly greater in microthrombi. D-dimer was also greater in microthrombi, and C5b9 complement was only present in the case of microthrombi who were COVID positive patients. Now, the findings in the COVID heart suggest an increased incidence of myocardial necrosis. Myocardial necrosis, contraction by necrosis, or focal necrosis, especially endocardial based, is a common finding in elderly patients dying of COVID-19. Similarly, epicardial coronary atherosclerosis severe with thrombosis and ST elevation MI, the thrombi are rich in platelet, fibrin, von Willebrand factor, D-dimer positive, but complement negative. Microthrombi are often observed in the myocardium in patients dying with COVID-19, and the thrombi are rich in fibrin, platelet 1 Willebrand positive, D-dimer positive, and complement C5b9 positive. Now, switching to myocarditis. Acute myocarditis is a disease with variable clinical progression and presentation. The pathogenesis of myocarditis consists of 3 distinct pathologic phases. Phase 1, there is direct destruction of the cardiomyocytes through the occurrence of virus-mediated lysis. Second phase is immune response, which is triggered by the myocyte injury and results in infiltration of natural killer cells and macrophages, followed by virus-specific T cells. And the third phase is the phase of dilated cardiomyopathy, which develops as a result of extensive myocardial injury and visible fibrosis. Histologic criteria of myocarditis were first described by the Dallas criteria in 1985, and they defined histologic evidence of intramyocardial infiltrates within the myocardium. These were associated with myocyte degeneration or necrosis or myocytolysis of non-ischemic origin. Then more recently, immunohistochemical criteria have been advanced, and they have overcome the shortcomings of the Dallas criteria. Myocarditis is defined according to the presence of abnormal inflammatory infiltrate defined as greater than 14 leukocytes per millimeter square. These include 4 monocytes per millimeter square with the presence of CD3 positive T lymphocytes greater than 7 cells per millimeter square. And this has been described in 2008 first, and eventually also shown by European Heart Journal as their criteria. I'm going to show you the clinical history and pathologic findings in 16 cases in whom we looked for myocarditis. As you can see, these patients had been ill anywhere from 2 to 29 days, and the heart rate varied according to the underlying cardiovascular disease. Epicardial inflammation was fairly common, as you can see, either mild or moderate, and most of them consisted of lymphocytes. However, when neutrophils were seen, it was usually if there was a myocardial infarction. Now, myocardial inflammation was rare. When it was present, it was mostly consisted of neutrophils, and rarely lymphocytes could also be seen. However, none of these fulfill the criteria of myocarditis. When we look at overall the virus presence, we were only able out of these 16 cases to show the presence of virus in the right atrium or in the left atrium in 1 case each. And none of these were high enough to be able to say that there was any inflammation seen there. None of them showed us any inflammation. On the other hand, virus was definitely present in most cases tested with for virus in the lung. And if you look at this slide, what we're trying to show is comparison of traumatic death with those of COVID-19 and seeing whether what type of inflammation we see, that is T cell or macrophage. You can see the positive cells, CD3 and CD68, was similar in both, whether they were control or COVID positive. However, T lymphocytes were positively seen more frequently in control than in COVID, but monocyte macrophages were more commonly seen in the case of COVID-19 as compared to control, but none of them reached the criteria to call it myocarditis. We also show a case of myocarditis, and you can see very well at low power, you can see inflammatory infiltrate, and you can also see majority are T lymphocytes, very rare CD68 cells. This is a total number of cases that have been published in the literature, 135 cases looking for myocarditis or not. 7 were endomyocardial biopsy, 128 were autopsy cases. And majority are 34 to 94 years in age, majority are males. And if you look at the myocarditis, reported myocarditis was 8.2 according to the authors. But when strict criteria are used, only 3.7 qualify to be called as myocarditis. So in summary, what I have shown you is there is clinical evidence of myocarditis may be considered high, that is 8.2, but using strict criteria, histologic evidence is low, 3.7. Of the 40 cases examined from Italy, we have not seen a single case of myocarditis. Most common cardiac findings in patients dying with COVID-19 is myocyte necrosis from 3 main causes, either epicardial coronary artery disease or microthrombi, and I didn't have time to show you these intramyocardial coronary emboli from PCI or from LV cavity. Thank you.
Great. That was an excellent talk. Now we have a few minutes to have some question and answers from the audience or from the panelists. I'd like to start the question and answer session by asking Dr. Guaiomi a few questions. You know, Julia, you have such incredible experience firsthand with the pandemic in Bergamo. What did you learn about the way we evaluate patients with cardiac injury that we could do better, that you perhaps regret or you think we should have done better in terms of, or we could do better now? And are there any therapies you thought empirically were working that we should be using now?
Okay, let's start from the second. I think that the cases we saw were very informative about the importance of the anticoagulation. And despite the fact that we have no evidence-based guidance in therapy, I think that we have enough data to support that anticoagulation is a pillar of the treatment as soon as possible when the patient comes in the hospital. We have observational data talking about full anticoagulation of prophylactic anticoagulation coming from the Mount Sinai in terms of a good impact in terms of outcome. I think that the current anticoagulation that we have in clinical practice is only one piece of what we would like to have. And there were data show tonight about the crucial role, for instance, of the complement, and start thinking about inhibitors of the C5 protein of the complement, or we can see differently in terms of anticoagulation, new potential drugs. I think this is one of the essential to be combined with antiviral drugs, and then we needed to have definitely a response from other therapy, glucocorticoids, especially at the inflammatory last phase, or the inhibitors of the cytokines. That is another very promising therapy. But today I think any type of decision is more guided by our sensibility and the clinical practice compared to have already the evidence. So very important to identify the pathophysiologic mechanism to try to focus on more targeting therapy. And regarding the first question that was how we can better characterize the myocardial injury, I think that we needed to take into consideration that these patients are infected. So first of all, we needed to differentiate the ones that have very low and continuous release of troponin. I think that they do not need anything more than to have a continuous serial evaluation and perhaps fast echo and follow-up echo. I think it's more important to have data in the mid-term of a follow-up. For the ones that they are coming in critical condition, like the young lady we saw, there is not too much that we can change in terms of imaging data. They are very quickly going to be intubating. They needed to be supported. We needed also to try to save the personnel to be contaminating. So I think that this is something that remain to be investigated and to be clarified.
Great, thank you. Rajiv, I think we have time for one question because we have a bunch of questions.
Gautam Kumar asked a great question. You know, Julio, you know, in the use of thrombolytics was sort of brought up by the Chinese initially during COVID, and we didn't really catch on in the United States because of the thrombus burden, and you already mentioned the intramyocardial thrombi. Gautam Kumar asked the question, is there any role for intracoronary TPA to deal with intramyocardial thrombi? And if so, how would you select those cases versus systemic TPA?
Okay, two different aspects. The first one is when the coagulation is changing, the TPA level in COVID patients is suddenly increasing at least 5 or 6 times. So we have a TPA produced at the level of the system, but in fact we have a much more important increase in PI1, the inhibition of the plasminogen activator. So I'm not sure that this suggestion could be completely valid for approaching the microthrombi. Regarding the primary PCI and the use of TPA, we did a completely different. In fact, we avoided to use fibrinolytics, and we use systematically primary PCI. I think there is a very important message that is coming from my hospital. In all the patients that we did, we compare COVID positive and COVID-19 treated with a primary PCI. In fact, the P on F ratio is the essential to understand if you are doing futile intervention, because if they are coming in severe respiratory distress, you can do everything, reopening the vessel, but you have a very, very high mortality compared to the COVID-19. So I think there is still a big space for deciding based upon the level of respiratory insufficiency, which type of therapy to approach acute ischemic events.
And I think, Julia, you know, that you brought up a great point. The reality is that thrombolytics or fibrinolytics works 50 to 60% of the time. And we saw, as did Shripar Bangalore from NYU, that many of the patients who presented with ST elevation had non-obstructive coronary artery disease. So in those situations, if you use just the EKG or even a POCUS with the EKG and gave thrombolytics, you were essentially treating nothing except small microthrombi. And so the utility of that is unclear.
I'm going to ask one more quick question before we go to Dr. Ramani. Stefan Tunev asked a very interesting question. Is there evidence that COVID-19 infects and damages cardiomyocytes directly, or the observed cardiac pathology is strictly ischemic?
I believe it is strictly ischemic, as we did, as you know, look for by PCR for COVID-19 in the hearts, and we did not find COVID-19 except in the left atrium and the right atrium. So I don't believe there is evidence that there is direct involvement of the myocardium at all. Invasion by the virus, by the myocytes themselves.
Okay, we've got a lot of questions, but I'm going to move on because I think we won't otherwise get to our other question and answer session. We can go back to these, Rajiv, in our larger question and answer session. So next, let's move to another talk. Dr. Byrne is going to present potential treatments under evaluation, focus on hypercoagulability and anticoagulation as a treatment strategy.
Good evening, and thank you for the invitation to present at this symposium on cardiac injury and PCI in the era of COVID-19. My name is Robert Byrne. I'm an interventional cardiologist in Dublin, Ireland, and I'm delighted to talk on potential treatments under evaluation. This is the agenda for the next 10 minutes or so. I'll start with a few words on the pathogenesis of thrombotic complications, building on what you've heard elsewhere. Say a couple of words then on clinical implications and potential interventions with regard to pharmacological therapy. Explain then why the Polymers F-coated stents might be a potential solution in patients at heightened thrombotic risk, and then give you a short update on the COBRA reduce randomized controlled trial, which is fully enrolled and will present primary endpoint data shortly. These are my disclosures. By way of introduction, then, the pathogenesis of thrombotic complications of COVID-19 have become increasingly clear as the pandemic has evolved. There's likely a spectrum of risk: patients with asymptomatic or mild infection, at slightly lower increased risk of thrombotic complications, and patients with moderate to severe COVID-19 infection seem to have a clear excess of thrombotic events, both in relation to venous thromboembolism and indeed to arterial thrombotic events. If you look at the risk factors, then many of the risk factors you would expect portend an increased risk of venous thromboembolic embolism, in particular, including consequences of acute illness, stasis, volume depletion, and multi-organ injury. If you look at the hemostatic abnormalities, then seem to be characterized by microthrombi in the pulmonary, but also in other vascular beds, and in advanced cases, intravascular coagulopathy. These go hand in hand with myocardial injury, which we know since early in the pandemic seems to complicate course in about 20% of hospitalized patients. The clinical outcomes then related to this increased thrombotic risk range from venous thromboembolism through to myocardial infarction and disseminated intravascular coagulation. The cardiovascular effects of this prothrombotic state are amplified by the systematic inflammatory response and the endothelial dysfunction that seem to go hand in hand with COVID-19 infection, and the increased risk in relation to arterial thrombotic events and acute coronary syndrome, and also in relation to myocardial injury, seem to be mediated in part through both microvascular dysfunction and microvascular thrombosis, and macrovascular dysfunction and macrovascular thrombosis. And you've seen some examples of cases related to these in the symposium this evening. In terms of the clinical implications in relation to cardiac disease and potential interventions, then I've just chosen two areas. One is the incidence of acute coronary syndrome. This is a study from Giulio Stefanini and colleagues in the Milan region. They looked at their heart attack network and saw that patients with ACS who were co-infected with COVID had a higher proportion of non-obstructive CAD when they came to the Cath lab than would otherwise be expected. This was more marked in non-ST elevation acute coronary syndrome, as you might expect, but up to 40% of patients presenting with ST elevation myocardial infarction didn't have evidence of obstructive disease and angiography. And I think in the symposium today, you've seen a case example illustrating this from Dr. Gualiumi. A second potential area related to the increased thrombotic risk in these patients is stent thrombosis. There are a number of case reports and small case series showing a link between COVID-19 illness and stent thrombosis. This is just one study from Spain. Authors reporting cases of acute on the left and late stent thrombosis on the right. The acute stent thrombosis in a circumflex stent in this instant, and on the right then a patient who had abrupt vessel occlusion in the proximal LAD many years after a previous LAD stenting, and it seemed to complicate the course of a COVID-19 illness. What can be done about this increased thrombotic risk? Well, in terms of current guidelines, there are a number of sources out there. This is from the NIH, but the ESC also has a document, and many of the other professional societies have guidance documents in relation to antithrombotic therapy. They say that hospitalized patients with COVID-19 should receive venous thromboembolic prophylaxis as per standard of care, and also in relation to anticoagulant or antiplatelet therapy to prevent arterial thrombosis. They say this is not indicated outside the standard of usual care in patients who don't have COVID-19. So we know there's a problem, but there isn't a specific guidance in terms of antithrombotic therapy at the moment. This is a position paper, Bigdelli et al., published in JACC on the cardiovascular and thrombotic complications of COVID-19. Apologies for this busy slide, but they call out in this table areas that require further investigation. You could see there's quite a few areas that require further investigation, but one is whether or not higher dose of anticoagulants confer net benefit. And while there aren't many studies examining the impact of antiplatelet therapy in terms of antithrombotic therapy with heparin, there are a number of studies ongoing. This, I think, is the largest, randomizing up to 3,000 patients. The treatment allocation is to heparin, either unfractionated heparin or therapeutic low molecular weight heparin, compared with usual care. Another approach that would apply particularly to patients at increased thrombotic risk who require coronary stenting would be to use stents that have a pro-healing and antithrombotic properties. The COBRA PzF NanoCoated coronary stent is one such stent, a cobalt chromium stent, thin strut, coated with a nanocoating comprised of polysine F, which is a stable fluorinated polymer. It has been shown in non-clinical studies to be thromboresistant, non-inflammatory, and pro-healing. You'll see some more data on non-clinical studies presented later in this session. This is one study from 2016 comparing COBRA PzF with vision bare metal stent in porcine model, and you can see here on the right of the slide that there was a significant reduction in neointimal area with the COBRA polysine F coated stent compared to the bare metal stent, and also in markers of inflammation in terms of struts with the granuloma or inflammation score seemed to be lower with the COBRA polysine F coated stent as compared with the bare metal stent. Ex vivo model investigations. These are some studies over the last couple of years performed by CVPath, show evidence of less platelet deposition on the COBRA PzF as compared with the bare metal stent. And you can see that nicely highlighted here in the representative images in the top left, and also significantly lower clot burden when compared with the Synergy drug-eluting stent, as you can see here on the right. Clinical data with the stent is building, first in man study through to a pivotal study through to broad clinical use registry in terms of the eCOBRA registry. The pivotal study, the PzF Shield Trial, 9-month clinical outcomes reported by Cutlip and colleagues back in 2017. 296 patients, you can see low rates of target lesion revascularization, 4.6%, and no cases of stent thrombosis. eCOBRA registry then was a broad clinical use registry. 940 patients were enrolled in France. You can see here also low rate of stent thrombosis, 0.6%, which is notable because a high proportion of patients had low intensity or short duration dual antiplatelet therapy. 6% only had monotherapy at discharge, and then a significant proportion had stopped DAPT by 1 or 3 months. So these positive results must be interpreted against the background of short dual antiplatelet therapy, which is important. Finally, then, to finish on an update on the COBRA Reduce trial. This is a large-scale trial, the largest trial ongoing with this technology, being coordinated by the ESA Research Center in Munich. 996 patients planned to be enrolled, and it is now fully enrolled. I'm delighted to be leading the study together with Adnan Castrati and an august group in the steering committee that you can see here. It concerns patients on oral anticoagulation who are undergoing PCI, all receive aspirin, and then there's a randomization to the COBRA PzF stent plus 14 days of clopidogrel, or an FDA-approved DES with 3 to 6 months of clopidogrel. The co-primary endpoints are BARC class 2 to 5 bleeding and a composite ischemic endpoint. The study hypothesis is that 14 days of DAPT and COBRA PzF will provide superior outcomes in terms of bleeding and non-inferior outcomes in terms of ischemic thrombotic events in comparison with the control group of standard DES and 3 to 6 months DAPT. Enrollment is now complete. The final phase of enrollment coincided with the COVID-19 pandemic, which of course caused difficulties for enrollment in many ongoing clinical trials, but we're very pleased that all 996 patients are now enrolled, and we hope to have the opportunity to share the data with you at the upcoming TCT meeting. In terms of take-home messages, then I think as the pandemic has evolved, it's been clear that patients with COVID-19 are at increased thrombotic risk, not only in terms of venous thromboembolism, but also in terms of arterial thrombotic events. The COBRA PzF is a potential solution for patients requiring PCI due to its pro-healing and effects and the low levels of thrombus on the stent in the acute phase compared with both bare metal and drug-eluting stents. And the data from COBRA Reduce, which is upcoming, and we hope to have this data available for TCT Connect 2020, will give more information on the clinical performance of this novel stent. Thank you for your attention.
Great, Robert, that was excellent. Next, I will introduce myself. I'll be talking about the thromboresistance of different stents compared under simulated cytokine storm conditions. Hi, I'm Alok Finn. I'm going to talk about stent choice when treating patients with COVID-19 induced cardiac injury. We're going to discuss the thromboresistance of different stents compared under simulated cytokine storm conditions. Here are my disclosures. So some background, 20 to 30% of patients with COVID-19 have evidence of cardiac injury, including troponin I elevation. And those with evidence of cardiac injury have increased mortality compared to those without. PCI may be indicated in some case with COVID-19, yet it remains unknown what type of device is safest. COVID-19 can induce a cytokine storm, which is associated with hypercoagulation with excess risk of thrombosis, perhaps including stent thrombosis, and the potential effects of PCI and COVID-19 have not been studied systematically. As you can see here, there's been some case reports suggesting increased risk of stent thrombosis, at least in these 4 cases that had COVID-19. This was featured in TCT-MD. A more recent study by Chowdhury et al. Basically studied a consecutive series of patients with STEMI with and without COVID-19 and divided them up by stent thrombosis, multivessel thrombosis, modified thrombus grade, blush grade, and D-dimer. And you can see cases with COVID had greater evidence or greater risk of stent thrombosis, greater risk of multivessel thrombosis, greater modified grade thrombus, grade 4 or 5, so larger amounts of thrombus in the coronary, worse myocardial blush grade, significantly worse, and greater D-dimer levels. So COVID-19 can induce a cytokine storm, and in this paper published in JCI Insight recently, they compared patients with severe COVID infection versus non-severe COVID infection patients. As you can see here, patients with severe COVID disease had greater requirements for oxygen than non-severe patients. They also had greater levels of inflammatory cytokines as indicated in the red circle. You can see cytokines such as IL-8, IL-1 beta, TNF-alpha, RANTES, MCP-1, IL-6 were all greater in patients with severe COVID versus non-severe COVID. And the results basically suggested an overexuberant response of pro-inflammatory cytokines is involved with COVID-19 in severely sick patients. And basically serum IL-6 and IL-8 were closely associated with disease progression. The purpose of the following study was to compare the thromboresistance of different stents under cytokine storm conditions. We wanted to specifically examine the effects of a fluorinated polymer coated stent, that is the PzF COBRA stent, versus an uncoated stent versus an abluminally coated drug-eluting stent, Synergy in this case. So in this study, we directly compared a thin strut cobalt chromium stent, that is the COBRA BMS, an identical COBRA thin strut cobalt chromium stent covered with a modified polysine F fluorinated polymer called the COBRA PzF NanoCoated stent. And we compared this to the Synergy stent, which, as you all know, is a thin strut platinum chromium drug-eluting stent with an abluminal PLGA bioabsorbable polymer coating which elutes everolimus. The luminal surface of Synergy, notably, is bare metal. As you all know, the relationship between medical device and thrombogenesis is extremely important. When a stent is placed, in the body, in the coronary artery, immediately we get platelets and fibrinogen prothrombotic aspects that adhere to the stent surface. The idea behind fluorinated polymers is that they absorb proteins, such as albumin, highly, and that protein surface protects the stents from the prothrombotic effects of platelets and fibrinogen, essentially preventing them from binding. This is shown here in this experiment where they looked at the effects of the PVDF HPF fluorinated polymer versus stainless steel on binding albumin. You can see albumin absorption was much higher in the fluorinated polymer surface versus the stainless steel surface, including after elution with a detergent, where the albumin stuck more highly to the fluorinated polymer surface. That also translated into less monocyte adherence to the surface for the PVDF HPF fluorinated polymer versus stainless steel. So the experimental setup, we used human whole blood, which was treated with 100 picograms per mil of TNF-alpha, one of the pro-inflammatory cytokines associated with cytokine storm, and 400 picograms per milliliter of IL-6, another cytokine associated with the cytokine storm. These concentrations were chosen in accordance with the highest blood levels seen in patients with severe COVID-19. We used both NanoCoated and uncoated COBRA PzF stents, as I discussed, and the Synergy stent. They were deployed in a flow loop system and circulated with cytokine treated versus control blood for 60 minutes. We processed the stents for immunofluorescence staining for platelets, followed by scanning electron microscopy, and we compared platelet adhesion to the stents under cytokine storm and control conditions. As you can see here, the in vitro cytokine flow loop simulating stent implantation in the cytokine storm conditions. You can see each stent was placed in a separate flow loop condition with human blood flowing through, simulating coronary shear rates. We used silicone tubing for this, and their blood was circulated for 60 minutes. So what did this experiment show? Well, you can see here when we compared non-cytokine storm conditions and we looked at platelet adherence, which is shown here in red on this confocal microscopy shown above, it's quite obvious the coated COBRA PzF had much less platelet binding than the uncoated and Synergy control stents. Overall, Synergy had the most platelet binding versus the COBRA PzF uncoated stent. That's shown here in the bar graphs, where we look at two separate aspects of platelet binding, both the platelet covered area under control conditions as well as the staining intensity, and we basically multiplied these to get a platelet adhesion value. You can see Synergy had by far the most platelet binding, followed by the uncoated COBRA PzF and the coated COBRA PzF. And that's shown here in the scanning electron microscopy. You can see here, this is the coated COBRA PzF blood control. You can see there's hardly any platelet binding shown on the struts, which correlates quite nicely between the SEM and the confocal microscopy with just a few platelets. The uncoated COBRA PzF under control conditions had more platelet binding than the coated stent, and that's shown here on the example shown with the confocal and the matching scanning electron microscopy, as well as the high power views. The Synergy by far had the most platelet binding. You can see here shown on the confocal microscopy as well as the SEM. There was far more, as I showed you, in the Synergy stent. So how about under cytokine storm conditions? What happened? Well, you can see overall there was more platelet binding under storm conditions. You can see here the coated stent, the COBRA PzF coated stent still had an advantage when it came to platelet binding, shown in red, as compared to the uncoated COBRA PzF stent and the Synergy stent. In addition, overall platelet binding was greater, but still the COBRA PzF stent performed the best in terms of platelet binding, as shown on the bar graph on the right, with much less platelet binding, almost the same under cytokine storm and non-cytokine storm conditions, versus the uncoated COBRA and the Synergy stent, which both had far more platelet binding. This is an example here of the high power SEMs. This is the coated COBRA PzF stent, showing you very few platelets adhering even under cytokine storm conditions. Here is the uncoated COBRA PzF stent, showing far more platelet binding, and that's shown on the nice matched SEM and confocal microscopy, and yet even more platelet binding on the Synergy stent, as shown here on the matching confocal and SEM. So here, and now I'm going to compare the appearance of the platelet binding under coated COBRA PzF under control conditions versus cytokine storm conditions, and you can see in terms of the amount of platelet binding, they're almost identical. There was really no difference in terms of platelet binding between the COBRA PzF stent under control conditions and under cytokine storm conditions. This was not the same for the uncoated COBRA PzF stent, where there was significantly more platelet binding under cytokine storm conditions than under control conditions, suggesting, again, that the cytokine storm does induce a hypercoagulability, which really is seen best in stents with a bare metallic surface. This was also seen in the Synergy stent, where really there was so much binding under control conditions that there was really not a lot of difference seen between control and cytokine storm conditions, perhaps a little bit greater platelet adherence, but not a lot, perhaps because there was already so much platelet binding. In conclusion, this is the first experimental examination of the performance of different stents under simulated cytokine storm conditions. The COBRA PzF stent showed the most favorable antithrombogenic properties. This was seen under control conditions, although it was more pronounced under cytokine storm conditions, especially compared to uncoated control stent, and as well as the Synergy stent. Metallic surfaces, that is those seen in the COBRA, uncoated COBRA, and the Synergy, perform poorly compared to fluorinated polymer surfaces in terms of platelet adhesion, and platelet adherence overall was highest in Synergy regardless of conditions. Platelet adhesion was significantly increased under cytokine storm conditions in uncoated, but not in the coated COBRA. The antithrombogenic properties can be attributed to the unique nanocoating of the COBRA PzF, and the use of COBRA PzF might be a promising treatment for COVID-19 patients given its thromboresistant profile. Thank you for your attention. Great. Let's move on to our last two talks. Dr. Matthews is going to tell us about the current status of COVID-19 in Florida, and what do I do if I have a COVID-19 patient with ACS, understanding thrombotic risk. This will take us back to the clinic and allow us to see what people are seeing firsthand in terms of their COVID experiences.
Hello, my name is Dr. Jay Matthews. I'm the director of the Cardiac Cath Lab at Manatee Memorial Hospital. I have the pleasure today to share some COBRA cases during the COVID-19 pandemic. Our hospital is notable for progressive cases since March. Our ICUs remain at capacity, and we've seen a lot of increased COVID-related thrombotic events, including increased stroke, VT events, acute limb ischemia, myocarditis, and COVID-related STEMI and NSTEMI. There have also been a lot of non-COVID-related halo effects, including delayed presentation MI with mechanical complications, including VSD, non-COVID-related VTE with very organized thrombus, and delayed presentation acute limb ischemia with neuromotor dysfunction, ultimately leading to amputation. These are our current numbers. We have at least 30 patients in-house with COVID, another 7 patients that are PUI, and another 40 patients that are under precautions. These numbers are down overall. In Florida itself, we have over 580,000 cases right now too, and in our county, almost 10,000 cases. These numbers are dropping. I want to share my first case, which is a patient that's 65 years old with hypertension and ongoing smoking abuse. The patient also is somewhat non-compliant, and he was refusing most of his medications, including heparin, despite presenting with troponin elevation. He had really non-specific symptoms, but his troponins were increasing, so we decided to take him to the cath lab. His labs were just remarkable for anemia, which may have been related to his long-standing alcohol abuse. In addition, he did have some elevation of his pro-BNP. His platelet count was okay. The only reason we knew that he was COVID positive was because we tried to check COVID status prior to performing procedures in the cath lab, and he was found to be an asymptomatic positive case. This is the reason why we didn't have a lot of the acute phase reactants that we would normally get with COVID patients. So in this case, you can see that there's a high-grade proximal LED occlusion, and despite this really severe lesion, the patient wasn't having a ton of symptoms, and you can see on this other view how significant this is. His LV function was remarkably preserved despite this occlusion. After crossing this, we ended up performing a high-pressure balloon inflation, in addition to using a cutting balloon as well too, in order to be able to deliver any equipment. We did perform intravascular ultrasound, which suggested that there was a significant amount of calcium. The COBRA stents did cross quite easily, and we placed a 2.5 stent in the mid-segment at 14 atmospheres, and also approximately another 3.0 stent as well at 14 atmospheres. Afterwards, we post-dilated this to 3.0 and 2.5 respectively, and you can see our results were excellent with improved TIMI3 flow. Intravascular ultrasound revealed no evidence of edge dissection or distal vessel compromise, and the patient did well. And now this type of patient in general, given the fact that his D-dimer was elevated as well too, normally we would have put him on some type of DOAC as well too for at least a month. And anecdotally, we've seen some improvements in these types of patients doing that type of therapy. However, he refused anticoagulation, but was able to take the aspirin and Plavix that we prescribed post-procedure. He's somewhat lost to follow-up at this point, unfortunately, so we're not sure what his ultimate outcome was going to be, which is one of the reasons why I was pleased that we did use COBRA stents in this particular case. This is a different type of patient, obviously a lot more sick. He's a 75-year-old gentleman with known metastatic pancreatic cancer. Status was chemotherapy 2 months earlier. He was admitted with chest pain, diarrhea, and fevers. In the later phase of the pandemic, a lot of our COVID patients started having more GI-type symptoms, and that was very typical. He had actually presented to the hospital 3 days early with atypical chest pain with negative cardiac enzymes. But on this presentation, he showed up with inferior ST elevations. His troponins, and this is a regular troponin I, was quite high at 40 with an elevated pro-BNP. In addition, his LDL was quite low at 14. His white count initially started okay, but then dropped significantly to 1.83. His platelets were dropping, and he was also anemic. In addition, as expected, a lot of these acute phase reactants were elevated with an elevation of a CRP, ferritin levels, procalcitonin, and ESR, and his D-dimer was also quite high. As expected, his COVID-19 did turn out to be positive. You can see here he has a proximal RCA occlusion with TIMI 0 flow. We went in with a Indigo CAT-RX catheter, performed mechanical powered aspiration thrombectomy, and afterwards we were able to restore flow. And you can see that there's an ulcerated plaque with thrombus in the proximal vessel, and also a high-grade occlusion distally going across the RPLV into the RPDA. So we went ahead and used the anchor balloon technique with a guideliner and stented the proximal vessel with a 4.0 COBRA stent quite easily at 14 atmospheres. IVUS did show that the vessel was quite large and ectatic at 5.5 centimeters. Distally, we went ahead and stented with a 3.015 COBRA stent at 14 atmospheres with quite nice results. And you can see the flow is better. The RPLV's got a little bit of slow flow. But fortunately, after giving intracoronary integralin, we did have some improvements there. The proximal stent was post-dilated 5.0. And you can see here we have TIMI 3 flow with some moderate residual mid-stenosis as well, too. Ultimately, the perfusion of the RPLV looked a lot better by the end of the case, and there was a decent myocardial blush. And you can see here on the LV gram that the LV function is actually relatively normal, with only some mild hypokinesis of the basal inferior wall. This is what his left circulation looked like as well, too. We ended up doing some intervention later on to his circumflex territory as well. He's got a very ectatic distal left main. Post-op, because of the elevated D-dimer, we did also put him on Lovenox injections in addition to Plavix monotherapy. The reason why we went with the monotherapy was we were concerned about his bleeding risk. And the patient did great from a cardiac perspective, but ultimately developed progressive pancreatic cancer and eventually went on hospice several weeks later. Thank you.
Great, Jay, that was excellent. Lastly, we're going to have Dr. Johar, who's going to present his experience with COVID-19 in New York and present a high bleeding risk COBRA case.
Hello, I'm Rajiv Johar. I'm the Chief of Cardiology at North Shore University Hospital. My talk today will be on lessons learned from the COVID pandemic, a paradigm shift in cardiac care, and the use of the COBRA stent in different cardiac situations. I have no disclosures. In early March, when the COVID-19 pandemic hit New York, and we were the epicenter, probably in the world, with our own health system having over 15,000 patients with COVID, the country shut down. The new norm became our recovery space becoming a COVID unit, our auditorium becoming a COVID unit, our cardiac short stay unit becoming a COVID unit, having a mobile hospital up the hill in a parking lot for COVID patients, and using an old cath lab to recover the few cardiac patients that did come to the hospital. We learned a lot from COVID-19. We also learned that there were a lot of cardiovascular manifestations, including hypercoagulable states with PE and stroke, especially in young people, and late presentation of acute myocardial infarctions, because COVID-19 did not treat cardiac disease, but yet patients came in to the hospital late. This lady, for example, presented only after she could not breathe. And we saw a lot of patients like this who had Q waves on EKG, very high BNP and troponin levels, And really, she had a closed LAD in cardiogenic shock with an echo that showed a dyskinetic apical wall and another echo that showed thrombus in the LV apex requiring Coumadin therapy. We saw a lot of patients with hypercoagulable states. This gentleman presented after COVID with bilateral PEs that with thrombectomy and the use of DOACs led to him being discharged home. We realized very quickly that blood thinners may help patients with severe COVID-19. And that led to the assessment of whether patients who are on these therapies and develop cardiac disease, what would be the best therapy? Well, we were part of the COBRA Reduce study using the COBRA stent. And so here's a situation of a patient who did not have COVID, but is a 70-year-old gentleman with atrial fibrillation on Eliquis, diabetes, who presented with chest pain, had a CT angio which showed severe mid-LAD and moderate right coronary artery disease, was on Eliquis, diltiazem, and metformin, and showed really a non-obstructive circumflex lesion, but a significant mid-LAD lesion, which with IFR was significantly positive, with FFR, sorry, was significantly positive. Patient got stented with the COBRA stent and did very well and was discharged home. These are the situations we can extrapolate into the COVID era with patients who have COVID on a DOAC or vitamin K and require intracoronary stenting. In this situation, the COBRA stent may actually provide the short DAP therapy that is necessary to decrease the risk of bleeding. COVID has not gone away, but we do see some glimmer of hope. Our recovery space that was a COVID unit is now back to us for cardiac cath. We are now seeing a resurgence of cardiac patients, non-COVID cardiac patients, but also COVID cardiac patients who are on DOACs, Coumadin, and other medications, coming in with unstable angina or stable angina with positive stress test, in which I think we can find a use for stents that require minimal DAPT therapy. I thank you for your time.
Great. That's fantastic, Rajiv. I think we have time for a few questions. There are some really excellent audience questions. I want to get to those before we close. Rajiv, I think I'm going to let you take it, turn it over to you, and you can just go ahead and ask the ones that you felt needed to be answered.
That'd be great. I think everyone did a terrific job, and it was very educational for myself in this whole process. Mohammed asked this really interesting question. Did you see any increased infiltration of inflammatory cells in the coronary walls? Julio or Renu, was there any data to suggest there's increased inflammatory cells in the coronary walls leading to a thrombotic state or increased thrombotic state?
Overall, there are cases in which you do see inflammation more, even non-COVID patients. So it's very hard to say, is there more inflammation? One would have to do a real comparison, age match, risk factor match, to be able to say whether there is increased inflammation in COVID. I've seen some cases in which definitely there's a lot of inflammation in the arterial wall, but I've also seen non-COVID patients with the same thing. So I can't say whether it is true or not.
And Renu, did you see any patients, was there any evidence of replicating virus in endothelial cells in these microthrombi cases?
No, we've not seen replicating. We've not seen in the endothelial cells. And as I said, PCR was negative in these cases, especially in the woman that Dr. Guayumi showed. We could not detect any virus in the heart at all.
Right. And look, Stephen Epstein asked a great question. Should all these patients, you think, be put on immunotherapy, since the primary problem seems to be an immune response that targets the coagulation system? Should we be using more immunotherapy? And I guess that goes to the question of the use of prednisone or the IVIG that's been shown in some studies.
Yeah, I think that's a great question. I think this is a situation driven by hyperinflammation. There's no question about that. And that may be something that, I think there, as you know, there was some data with dexamethasone. It's been some controversy about it, but there was some initial data that showed it was promising. I think the immunotherapies are promising. We certainly don't want to get rid of the idea of clearing the virus, but we don't want the body to have a over-exuberant inflammatory reaction, which I think is really what the cytokine storm is all about. And that's why we're getting a lot of these hypercoagulable states. And I would follow that up by asking one question. Dr. Tunev asked a question about whether or not the implications of Dr. Ramani's talk are that really it's a thrombotic problem. It's not as much a problem of inflammation, direct virus inflammation of the myocardium. And so is antithrombotics the way to go in order to protect the heart? That's Dr. Tunev's question.
I think the answer is going to be probably yes. From a clinical perspective, I think the answer is going to be yes. And the reality is that we saw from the Mount Sinai studies that use of DOACs was very beneficial in COVID patients, not just during the peri-COVID era, but really in the 3 to 6 month time period. I wonder in patients like this, and I know we talked about thrombolytics and there was really no utility. The question is there any utility of 2B3 agents? Intracoronary 2B3 agents in these situations where you have, say, slow flow, you have a hyperthrombotic state, which you saw a lot of patients like that. Robert, Jay, what do you guys think about that?
Well, in the case that I showed, I did in fact do that intracoronary during the case, and that did help. But in that particular patient as well too, they were also high bleed risk. So, it's going to be a matter of mitigating the risk of bleeding versus the risk of thrombosis. And if you have a patient that continues to be on, low molecular weight heparin post-procedure plus dual antiplatelet therapy, do you also then consider putting them on a 2B3A? That's a lot of agents all at once, and obviously it can be problematic.
Jay, can I interrupt and ask one question?
Yeah.
In your slide, you said something about you look at the D-dimer levels after the first case you presented. It was a non-STEMI COVID-19 patient. You said, I examined the D-dimer levels, and based upon that, I was electing to put him on an anticoagulant. He refused ultimately. Where did you get the data about this D-dimer, and where's that coming from?
The problem is, so it's obviously that's controversial as well too, and that's not necessarily related to ACS per se, but it comes to the VT literature. And our protocol at our institution has been to place these patients either on low molecular weight heparin or a DOAC post-procedure if they have an elevated D-dimer on presentation. So for some of these patients, we think that they could have, obviously if they have ACS, but they could also have, a potential for VT as well. And if there's a high clinical suspicion, then we would treat them as such. And obviously, in that recent review paper that was published in JACC, that is a very controversial paradigm, and also one that's not with a lot of evidence. So these protocols, UNC does this. Obviously, Mount Sinai has also done this to a certain degree as well too. But the ACS population, obviously, then you have to balance out. Do you continue them on the dual antiplatelet therapy plus also the DOAC as well too? And what we've done, especially with COBRA, is and again we're waiting on COBRA Reduced to come out to really guide us in this, but we go with a shortened duration of dual antiplatelets and then continue the DOAC for at least a month.
And Robert, I guess I would ask you one question. You pointed out to I don't know, it was an opinion paper or what it was, that's a review paper in JACC. You were pointing to the guidelines and you were saying as yet there's really nothing that is recommended for arterial thrombosis. You said there is a recommendation of prophylaxis for venous thrombosis, which is quite clear in the COVID patients. Do you think the guidelines, Robert, are not aggressive enough in terms of what we should be doing in standardizing therapy in a situation where we're slowly learning this is more of a thrombotic problem for the heart than it is anything else?
Yeah, I think it's a great question. It's becoming clearer, I suppose. One of the things, of course, that we learned with this infodemic that accompanied the pandemic was that we should be a little bit circumspect about emerging studies and emerging data. So it's, on one hand, you've got to act rapidly and then adapt as new evidence becomes available when you plan how to treat these patients. But on the other hand, you've got to be a little bit circumspect. I think clearly there is a lack of guidance as regard to arterial thrombosis. There's a little bit more evidence, and we've highlighted a couple of times already the evidence for antithrombotics from observational studies in venous thromboembolism. But I think there is a rationale for potent antithrombotic therapies to inhibit some of the arterial complications that we've seen today. And one final comment, you know, when you look across the literature, it does seem to be that bleeding is not a particularly strong component of the systemic illness associated with COVID-19. So it may be that there is a place for potent upfront antiplatelet and antithrombotic agents. And last thing I will say is that since we recorded, COBRA Reduce has been accepted for presentation at TCT Connect. So look forward to sharing the data with you then.
Robert, one more question for you. How does COBRA Reduce data inform us in terms of our COVID era? Does it inform us? Does it change anything for the way we think about treating COVID patients? It seems like Jay's already recommending anticoagulants on top of antiplatelet agents. Is that something that COBRA Reduce can help us sort of figure out what the best therapy? There's a lot for a patient to be on an anticoagulant and dual antiplatelet therapy. So I'm just wondering, is that something that, you know, we can use going forward, just serendipity wise?
Yeah, I mean, you know, there's a lot of kind of moving pieces go into that question, and Jay already mentioned it in his answer. When you're talking about prolonging DOAC therapy, then after the procedure, what do you do with the dual antiplatelet therapy? So, you know, in some respects, COBRA Reduce will give us some insight into the kind of relative risks benefits or net clinical benefit compared with standard DES and a slightly more prolonged dual antiplatelet therapy. So it'll give us some guidance. Of course, it's extrapolation.
Rajiv, any more questions before we close? Did you want to get to anything else or not?
Oh, I think, you know, we've answered most of the questions, and I don't think there are any pending questions. I just think that, you know, with COVID-19, the abnormal was the norm. I mean, in other words, we saw so many things that we were shocked by, you know, seeing the 25-year-old with having strokes, or the 35-year-old with a pulmonary embolism bilateral. So we saw it, and I think we learned a lot from our colleagues in China and Spain and Italy. And I think, you know, if, hopefully never, but if it does come back, we'll be able to deal with it in a better way, because COVID does not treat cardiology.
Yeah, there's no question. Okay, I think we've about done it, and we're basically out of time. I just wanted to thank everyone. I hope tonight's presentations really informed your knowledge of the effects of COVID-19 on the heart. We, I think, heard many dramatic and sometimes disturbing stories, which highlight the importance of understanding more about the virus's effect on the body overall, and especially the heart. Obviously, I'm a biased person, I'm a cardiologist. If you have any questions that were not answered, we tell you that please email us at info@cvpath.org or info@celanova.org, and we will get back to you. The webinar will be posted on our website in its entirety if you know someone that missed it and would like to see it. In closing, I really would like to thank you guys out there for joining us tonight, with a special thanks to our speakers and to our sponsor, Celanova, for sponsoring this special webinar. I hope very much that you enjoyed the talks. I'm wishing you guys all a safe and healthy weeks and months to come. Thank you again for attending. Good night.
Thanks, guys.